this is going to be very informal, I guess, and quite brief, and then myself and Roisin are happy to take any questions and that afterwards. So I just want to thank Roisin as well for making the time to be here today and for sharing your story, which I know is always hard, but it really makes a difference for other patients and their families. As you know, this is part of our pre-budget process and putting pressure on government to provide the necessary funding for the National Cancer Strategy. Up to 1 in 10 cancers have a familial link. That's including, as Roisin will talk about, the BRCA gene, which is related to breast cancer and ovarian cancer, and Lynch syndrome and bowel cancer. So identifying this link as early as possible is really important, both for patient, because it can determine the treatment options that are available to them and the opportunities to personalise the medical response for their particular type of cancer, but also, as Roisin will touch on, for the whole family. And when one person in a family is told that they have a cancer that is genetically inherited, it causes huge distress for everybody else. And that's why it's really important that that people don't have to wait to get that information, and that if they need to take preventative action, whether by having surgery or other treatments, that they can do it as soon as possible to reduce their risk of getting cancer. So genetic testing is so important for the patient themselves and for their families. That's why it was called out as a priority in the National Cancer Strategy. And the National Cancer Strategy commits to making sure that there are proper genetic services in place, from testing to counselling to access to preventative treatments or increased surveillance, depending on what's appropriate for the individual. And that's why it's so horrifying to us at the Irish Cancer Society that 2 years on, there are still over 2,000 people waiting for genetic tests. Of whom not everybody, when they have the test, will find that there is a familial link, and that will be, reassuring for them to know that there isn't a problem. But when you're waiting for 12, 18 months to get that information, and of the 2,000 people that are on the list, nearly half of them are waiting over 12 months. That's 12 months of fear and anxiety and wondering if you're at risk of a serious cancer, that you should be doing something, that you could be doing something to reduce your risk of, and that causes huge anxiety for people. We think this is really shocking, and that's why we're highlighting this ahead of the budget, to call on the government to provide the resources that are needed for genetic testing. Unfortunately, little bit, as I said, was called out in the National Cancer Strategy. So far, little progress has been made. They have appointed a national lead for genetic testing, Professor David Galler, who is a really superb individual, and also a national cancer lead for psycho-oncology, to make sure that patients and their families get the psychological support that they need. So 2 fine people have been appointed as kind of national experts in this area, but they haven't been given the resources and the teams they need to provide national service. And if you think about even just the comparison between, say, Ireland and Manchester, so Ireland with a population of 4.8 million people, we have 4 consultant geneticists and 5 genetic counsellors. Manchester, with a population of 3 million people, has 16 consultant geneticists and 33 genetic counsellors. So that's the level of under-provision that we're talking about here, and the progress that needs to be made to make sure that patients and their families are getting a decent service and not being left with unfair distress and late diagnoses. But the other issues that we wanted to highlight today as well, in the context of the budget, are the lack of progress that have been made on other areas, other commitments in the National Cancer Strategy. While progress has been made in some areas, so for example, rapid access clinics for prostate and lung, in other areas we haven't moved at all in the last 2 years, and in some we've actually gone backwards. So for rapid access clinics for urgent breast referrals, the number of people being seen within the 2 weeks for urgent referrals has actually decreased since 2017. We've gone back In August 2019, the colonoscopy waiting times were the highest that they've been since the strategy was published in 2017. And we also know that there are less patients on clinical trials now than there were when the strategy was published. So in 2018, the number of patients on trials was 1.5% of all patients, down from 3% when it was published, and compared with a target in the strategy of 6%. And what those numbers mean, because sometimes we miss, the stories behind those numbers, what that means is that there are patients that are not getting access to innovative drugs that could save or prolong their lives because they can't get them through a clinical trial. So that is really, really serious for those patients and their families, and it's horrifying to us that things are not only not getting better in areas like trials and some of the waiting times, but actually getting worse. So that's why we're calling on the government to make sure that there is sufficient funding provided in budget 2020. Last year we had a situation where after the budget, the HSC said in its service plan that it hadn't been given enough money in the budget to stand still, so to provide existing services to a growing number of patients, let alone to deliver the improvements promised in the strategy. And that's simply not good enough. Why publish a strategy if you're not actually going to deliver it? It just gives false hope to people who deserve better, to people who deserve to have some of the basic services like genetic testing that are available anywhere else in the world with a decent cancer system. So that's why we're highlighting these issues today, and I want to thank Roisin for coming along to speak about the impact that this has had on your family and why you think it's so important that this is addressed in the budget.
Thank you. Thank you. Well, my name is Roísín Prizeman, and I carry a BRCA1 mutation. So BRCA, BRCA, stands for breast cancer, and we all carry BRCA genes, both men and women, and the job of those genes is to suppress any cancerous cells that may develop and suppress them from developing into tumours. So unfortunately, the mutation that I have means that there's a fault on my gene and it doesn't do the job it's meant to do. So I carry a lifetime risk of developing a breast cancer. My lifetime risk of that is up to about 87%, and my lifetime risk of developing ovarian cancer is up to 65%. And I guess just to give a little bit of context, how this whole BRCA story came within my family. My mum passed away. She was age 41 and I was 4, and she passed away of breast cancer. My mum had 9 sisters, 7 of whom had breast or ovarian cancer. So we had huge incidence of cancer in our family. It's always been, I suppose, a reality throughout my childhood as long as I can remember. But at that time, we didn't know anything about BRCA. It wasn't actually really until the early 90s that we learned about BRCA. But you can imagine the absolute horror in my family when the cancer started presenting itself in the next generation. So I had a number of first cousins who developed a breast cancer, some of whom survived, some didn't. And my own sister was diagnosed with breast cancer when she was age 40. She went on to have a bilateral mastectomy, and she was re-diagnosed with breast cancer at 42, which was horrific. So at that stage, she went for genetic testing and discovered that we had this BRCA1 gene in the family. You can understand it probably wasn't a huge surprise to us, but it was still very difficult to deal with that information. Anybody who discovers they have a BRCA gene in their family is presented with huge challenges, not least of all in terms of communicating that information within the family, which can be incredibly difficult. It needs a lot of help and a lot of support, and that's not something that is ever offered or given to us here in our country. But on the basis of my sister testing positive for this BRCA mutation, I then had my test done in 2011, and I tested positive also for the BRCA mutation. So I very quickly decided that I was going to have risk-reducing surgery. I was advised to have an oophorectomy, have my ovaries removed, and that would reduce a certain amount of my risk. So I had that surgery in 2011. In fact, I had a full hysterectomy in 2011, and I opted for the gynecological surgery first because emotionally I just wasn't ready to have breast surgery. I just couldn't possibly get my head around having that surgery at that time, and I thought it would be easier. I thought the gynecological surgery was actually going to be the easier surgery because in my head, well, they were internal organs, so nobody knew anything. What I didn't realise was that actually the gynecological surgery is the one that has really far-reaching consequences on quality of life. And I didn't know that at the time. I didn't receive any form of counselling around having that elective surgery. Years later I discovered that I probably should have been on medication to protect my heart health and my bone health. I didn't know that. I wasn't told about that. So I had post-surgery I was put into a very aggressive menopause, which is incredibly difficult. It's just not something that was talked about or that I was advised on. So 2 years later, in 2013, I decided I was going to have my bilateral mastectomy, and I will say, in fairness, that probably Angelina Jolie helped get me across that line, because in 2013, in May 2013 that year, she went public on having her surgery, and she has made such an immense difference to women like me, because I think a lot of us kind of went, well, if she can do it, maybe I can too. So I had my bilateral mastectomy in December 2013. I had a wonderful medical team. I have to say the care I got at St James's Hospital was excellent. There were gaps. There really were gaps. I had one consultation with psych services pre the surgery, which I was told was mandatory to ensure that I fully understood what I was about to do and what I was signing up for. And that was it. There was no counselling before the surgery or after the surgery. I did actually go for counselling myself privately, which I sought out and paid for privately. My surgery, I had bilateral mastectomy and breast reconstruction all at once. My surgery was very successful. I'm very happy with my outcomes. And after that, I decided that I was going to train up as a peer support volunteer with the Irish Cancer Society, because I couldn't find anybody to talk to before I had my surgery who was actually in the same space as me. I knew a lot of people who'd had cancer, but I didn't know anybody who hadn't had cancer who was going to have elective surgery. So I trained up as a peer support volunteer with the Irish Cancer Society, and I've been performing that role for the last 5 years. And over the last 5 years, and certainly over the last year in particular, I've become increasingly concerned in the decline around genetic cancer services that people are experiencing. I've been talking to both men and women who are telling me they're waiting, a long time to have the genetic test, and then there are people waiting for surgery up to 3 years. Not only are people waiting for surgery up to 3 years, there are cases where, for example, a woman I spoke with, she was given a date for her surgery. She has 3 young children. She had herself all prepared. She had to travel from rural Ireland for her surgery. She was prepared. She had her children farmed out to different family members, everything ready to go, and her surgery was cancelled the day before. She was absolutely devastated. You can just imagine. Nobody can. Sorry. Nobody can imagine the pain of making a decision and facing a surgery. Thank you. To have your breasts removed, and to think that, people you will go through that. The surgery might be cancelled, and there are no psychological services at all offered to people, and it's just absolutely wrong. There are recommendations in the National Cancer Strategy which haven't been acted upon. They talk to psychological services, but they're simply not there. And we really need to understand the needs of this cohort of people. We are growing in numbers, and you might ask, well, why are we growing in numbers? How can that be? Well, here's how it can be. For example, in my family, I was the first generation to be tested. So subsequent generations are obviously, being tested now. Our children are putting themselves forward for testing. Women are being tested at a younger age. They are facing very difficult decisions around making choices. There's the whole concern around, when a woman tests positive for a BRCA mutation, she's told, and I've spoken to women who've been told this, out you go, have your kids come back, get your ovaries out. And how on earth are you supposed to actually assimilate that type of information, make those decisions, and with no support? So we absolutely need to have those services put in place. We need a model of care for hereditary cancer patients. We need that model of care countrywide. Again, we have a 2, 3, 4 and 5 tiered system. You have people in Dublin having a completely different experience to people in Kerry. And that's right across the board, from when they choose to have genetic testing to if they choose to engage with the concept of surgery, or for screening, screening pre-surgery, screening post-surgery. There's a different story. I talk to people all the time. I myself, for example, was discharged from the family risk clinic last year because I was told, well, your risk is less than that of the person in the street, so we don't need to see you. Now, that may be so, but I still carry a BRCA1 mutation, and the fear will never go away. And the BRCA1 mutation is also associated with pancreatic cancer, colon cancer, prostate cancer in men. We get no screening for anything like that, and we absolutely need to have this addressed as a matter of urgency, because people's lives are severely impacted by testing positive for a BRCA mutation, really severely impacted. And from the first point of contact, any family that engages with genetic testing should absolutely be offered counselling. They should be offered counselling. You should be offered counselling as an individual and also as a family, because it is very difficult in terms of communicating. It's difficult. You absolutely need to have support in your corner. I'm very lucky. I have wonderful support in my personal life. I'm extremely lucky, but there are people out there who don't have it. And we are failing these families, we are failing these people. We're failing them by making them wait, agonising lengths of time for the services they need, and then by not actually delivering those services in a timely manner, and by not following up on their needs thereafter.
So sorry you had to go through that. I can only imagine what it's like to get that kind of news and then not have anybody who can actually talk you through it. That's why, sometimes you look at the National Cancer Strategy and there's lists of, dozens of recommendations, and it's hard when you're reading it, I suppose, to see kind of the human impact of not delivering them. And this is what it means. This is what it means when you publish a plan and you don't actually follow through and provide the resources. This is the impact that it has on patients and their families, and it's just not right. And that's why we're highlighting this today, and I just want to thank Roisin as well for the amazing work that you do with the peer support programme, because it's an incredible programme, and I've met people since I started here 18 months ago that have benefited from it and just found it an incredible support to have somebody else that you can talk to
Mhm.
that actually understands what you're going through. And we think we need to shout about that a little bit more as an organisation, so
Yeah,
more people know that
absolutely.
it's available, because it's a really lonely place when
It is.
you've been given bad news and you don't know anybody in your circle of friends
Yes,
that actually
yeah.
understands it. So
It's just such a complex area,
Yeah.
you know. It's you know, as I said earlier, it's not like it's ever over, you know, because it's not like you can say, well, I've had my surgeries now, I reduced my risk, that's all good, I can move on, because it is genetic.
Yeah.
It's never over.
Yeah.
You know, there's always the next generation to worry about.
I think the crazy thing, I mean, this is genetics, like, and the potential of genetics to massively improve cancer care is phenomenal. Like,
Yeah.
the reason that we're able to, as you said, now test the
Yeah.
current generation is because of progress in medicine and in diagnostic tests. And then that means that, like, for patients, we've got much more personalised treatments that have,
Yeah.
once we know which particular genetic mutation has caused that form of breast cancer, prostate cancer, or other cancers, once we know that, there are amazing new medications that targeted to
Yeah.
that mutation can give people so much better outcomes than they would have had 5 years ago, and enable other family members to take preventative action. But that only works if you can get the tests and if people have the support they need to be able to make those decisions. So it's crazy that I think we've managed to turn an area that's incredibly positive and hopeful, and where other countries have managed to use genetics to build a really positive cancer story. And here, because of under provision and because we have the 10th of the genetic cancers that they have in Manchester, families are going through this experience instead of it being a more supportive one.
Absolutely, and I mean, you know, cancer prevention is where it's at. We all know that, and that's where we need to be investing our money.
Yeah.
And it's also important to note, as I alluded to, that these services have declined. The Family Risk Clinic was closed down in the Mater Hospital last year, and the Family Risk Clinic at St James's Hospital was temporarily suspended because they couldn't offer timely mammography, and people just received letters to tell them that their appointment had been cancelled, they couldn't be offered timely mammography, and that if they had any concerns, that they could attend the breast clinic. In other words, if they had concerns, as in if they found something that they were worried about on their breast. Now, that's not where genetic cancer services should be at. Wait until you find something. It's completely unacceptable. You know, and as you say, it is a very positive, we can look at it in a very positive term. I consider myself very lucky that I have the information that I have the knowledge, and that I, you know, was able to make decisions to reduce my risk. I'm extremely lucky. I'm one of few females in my family who has not personally had breast cancer. And I am very lucky, but you know, that's what it should be, that's what we should be talking about, where that space, that it is very positive, but it doesn't feel positive for people who are waiting, and all of those services, it's really actually peer support that people are leaning on all the time, because they're not actually getting counselling services, and they're not being given, you know, appointments in a timely fashion, and our hospitals are doing the best that they can do, but they don't have the resources.
Okay, thank you. Does anyone have any questions, or would you prefer to do interviews separately? Yeah. Yeah. Okay. Thank you.
Thank you. Thank you.